renal function test, the liver function test, and UPCR at 24-hour routine must be done, which was done for this patient. But she missed all the other because of being lost to follow. That is renal function monthly, proteinuria monthly, blood pressure weekly, bacteriuria each trimester, and GDM screening at the earliest. Whereas fetal surveillance protocol, early pregnancy scan must be done less than 12 weeks to accurately predict the EDD. That was done for this patient. But at 12 weeks, pupil translucency must be done. And 18 to 20 weeks, fetal anatomy, cervical length, and placental position and function must be assessed, which the patient has missed. And monthly from 24 weeks, fetal growth and AFI must be seen. And in case of IUGR, twice weekly biophysical profile, the Doppler evaluation of umbilical cord or non-stress test must be done. And see, the chorionic villus sampling or amniocentesis must be done only when required. So, he presented to us nephrology department at 28 weeks of gestation. And at the time of examination, she had pallid and periorbital puffiness with a blood pressure of 140 by 90. And in anthropometry, she had a weight of 61 kg and her BMI was 23.8 at the time of presentation at 28 weeks of gestation. So systemic examination was within normal limits with even fundus corresponding to the gestational age. So at 28 weeks of gestation, her investigations were as follows. So she had an anemia with a HP of 7 and her urea creatinine was reached 77 and 6.4. Her liver function tests and electrolytes were normal. Her CUE had trace protein and UPCR was 0.3. So we can see that her RFTs are broadly reading. So we formulated a management plan for her going forward. So that is what is the dialysis prescription and the diet and BP control and anemia, MBD and fetal and maternal monitoring and also the indication for delivery. So this is the patient. So owing to her grossly elevated renal parameters, her creatinine being 6.4, she and her family were counseled regarding the need for RRT and she was started on hemodialysis. So what are the indications to initiate renal replacement therapy? How would you modify it in the pregnancy? So apart from the conventional indications of RRT like azotemia, fluid overload and all, we should also commence hemodialysis at the blood urea nitrogen of more than or equal to 50 mg per dl with a target pre-dialysis blood urea nitrogen of less than 50 mg per dl in a pregnant woman. So we call it intensified MHD, and it needs to be done frequently, like 5 to 6 times a week, and sometimes even longer sessions might be required. So this intensified MHD decreases the risk of polyhydramnion and helps to achieve the target blood pressure. It increases the birth weight and it improves the maternal nutrition and chances of live birth. So ideally, if the patient has no residual renal function, almost 36 hours per week of MHD needs to be given. But if the patient has even minimal residual renal function, even 20 hours per week will suffice, or else we can stick to a target pre-dialysis urea level. So, what do the different guidelines say about it? So, KDIGO in 2015 has mentioned that long frequent hemodialysis needs to be done in the setting of pregnancy, whereas UK CPG 2019 guidelines have mentioned that big pre-dialysis blood urea nitrogen must be less than 35 mg per day. And hemodiafiltration is safe and well tolerated with 100% live birth rate in a single center study of 5 patients. This was done in this single center study, but it is not widely available, HDF. And another important thing to remember is that the KT by V, this is not validated in pregnancy, and thus it should not be used routinely as a marker of dialysis adequacy in pregnancy. So we kept our patient on an intensified MHD plan. We gave her MHD 5 by 7, almost 20 hours per week, but the target blood urea nitrogen was less than 50 mg per day to minimize the ketotoxicity. And ultrafiltration removal, we did it based on interdialytic weight gain. We minus the normal weight gain during the pregnancy and also based on her hemodynamic state. So we did maintain a low blood and the dialysis flow rate, that is 150 to 200 ml per minute, and dialysis flow 200 to 300 ml per minute. So coming to ultrafiltrate management, this volume management is always challenging in case of pregnancy, because in pregnancy we have to adjust dry rate every week because it increases like 0.5 kg per week in the second and last trimester, and hypovolemia, it needs to be avoided. And apart from the interdialytic weight gain and volume status, we have to also keep a check on the, we have to also see the BP of the patient. And it is particularly difficult because there are actually no reliable markers for volume status of the patient, because fetal edema occurs in healthy pregnancy as well. So in certain studies, they've indicated that if a baseline hematocrit and albumin values are available, which were measured early in the pregnancy, then maybe in late pregnancy during third trimester and all, rising values can be used as markers of volume contraction. But the only thing is that they have no particular discriminant value, and the vice versa is not true. Like the falling values of hematocrit and albumin cannot be taken as indicators of overload because they are influenced by far too many external factors. So we also did a 2D echo of our patients, which suggested an EO of 60%, and the rest is normal. So the UF removal rate is also equally important because here we are dealing with fetoplacental circulation also. So how much should be the UF removal rate to ensure that the fetoplacental circulation is not compromised? So it is 6 to 8 ml per kg per hour. So we should be aware of this also. And Doppler sonography of umbilical artery is a simple non-invasive method which aids in determining safe UF rate, and also it can be used for the future fetal follow. Coming to the dialysis composition, so the dialysis composition for pregnant women, potassium needs to be in the range of 3 to 3.5 milliequivalents per liter, and dialysis calcium must be maintained between 2.5 to 3.5 millimoles per liter. And in the event of hypercalcemia, even low calcium dialysis can be used, like 1.5, or sometimes calcium-free dialysis are also available if needed. And bicarbonate should be maintained at 30 milliequivalents per liter, and we may reduce it to 25 as per serum bicarbonate. And anticoagulation, heparin in pregnancy is safe, so it must be used. And for our patients, calcium and bicarbonate levels were normal, so we use the routine standard dialysis which we use for sterile population. So this is the composition of the dialysis that we use. So after we stabilized the patient, after starting with intensified MHD, we went ahead with evaluation of her native kidney disease. So her ultrasound actually showed renomegaly of right kidney, 14 to 7 centimeters, with grossly dilated PCS and proximal ureter. Her left kidney was contracted 18 to 6 centimeters with increased decotection, mildly dilated PCS. So we went ahead with MRI abdomen plus pelvis, and that showed again renomegaly of right kidney with grossly dilated PCS and proximal ureter with cortical thinning, and as mentioned, the distal ureter is normal, so a possibility of mid-ureteric stricture was entertained, and left kidney was shrunken again. So we took a urology referral and cystoscopy was done for this patient, but during cystoscopy, there was no evidence of any stricture. So we made a diagnosis of possible cat foot in this patient. So after for the management part, he underwent right URS plus TJ stenting under spinal anesthesia. So coming to the next most important part, frequently neglected in our clinical practice, that is diet prescription. So if we can categorize the patients into CKD-ND, CKD-5D, and pregnant CKD on hemodialysis patients, then the energy requirement is given in all the three categories, that is 25 to 35 kilocalories per kg per day, except that an extra of 30 kilocalories need to be added for fetus in pregnant women. Coming to protein, CKD-ND is 0.8 grams per kg per day. CKD-5D is 1 to 1.2 gram per kg per day, whereas in pregnant CKD on HD, that is 1.5 to 1.8 gram per kg per day. So, coming to the other nutrients, double doses of water-soluble vitamins need to be given, and folic acid of 5 mg per day. And liberalization of dietary phosphate need to be done because of intensified MHD, there is a risk of hypophosphatemia in this patient. So, almost 1.2 gram per day needs to be given to the patient. And iron of 200 mg per day. And sodium actually has to be individualized. But various sources mentioned that we should maintain a low salt diet. Kedoki saying that it should be less than 100 millimoles per day or less than 2.3 gram per day. And calcium 1.5 to 2 gram per day. So this is actually the diet provided in our hospital for this pregnant patient. So this is the diet plan that was formulated. And when we calculated the energy and the protein requirements for this patient, our patient received about 2,000 kilocalories per day. So for her, who is weighing 61 kgs, it comes to around 30 kilocalories per kg per day. Whereas protein is 73 grams per day, which is about 1.5 grams per kg per day. Coming to hypertension management, KDO mentions that a target systolic BP should be less than 120 mm of Hg for CKD. So for the patients in regular follow-up, this is to be achieved before pregnancy with pregnancy-friendly drugs which are planning to pregnancy. And coming to pregnancy targeting ESKD, it should be 140 by 80 to 85 mm per Hg, and it shouldn't go below 120 by 70 because increased diastolic pressure is again it is associated with worse fetal outcomes, and it also it also causes fetal hypoprotein. So the pregnancy suitable antihypertensives are methyl-dopa, lebetalol, hydrolysine, prazosin, and nifedipine. And diuretics must be avoided unless in extreme situations like pulmonary edema, substantial peripheral edema. Aldosterone antagonists must be avoided, and atenolol is usually associated with fetal growth restriction. And our patient is controlled with nifedipine. Coming to the AC inhibitors and ARBs, so these are completely contraindicated in second and third trimester. They must be avoided in first trimester as well. And the congenital defects which are associated with these drugs are renal tubular dysplasia, postnatal kidney failure, oligohydramnia, growth restriction, pulmonary hypoplasia, and hypocalcemia. So the important point to remember is that in progressive proteinuria kidney disease, especially in diabetic nephropathy, these ACE inhibitors and ARBs must be continued until this period of pregnancy or diabetes. Uh, Whereas in case of non-proteinuric kidney disease, it should be stopped even before the attempts to conceive. So coming to management of anemia, so our patient had anemia at presentation with a HP of 7 gram per day. So what is the target HP in pregnant women of CKD and how to manage? So similar to management of anemia in CKD, iron stores have to be depleted first before starting ESA. So both the FCM and iron sucrose are shown to be safe in pregnancy. And a trial of IV iron can be given to correct the deficit, and then HP can be repeated after 2 weeks. And if the target is not achieved, then ESA can be initiated. So, for women of CKD 5D who are already on ESA, during pregnancy, ESA dose would have to be increased by 50 to 100%. So, we should always keep a track of that. We should always send HbA every 2 weeks. And all the formulations of ESA have been reported to be safe in pregnancy, and ESAs do not cross the placenta. And HbA are not recommended in pregnancy. Target hemoglobin must be maintained between 10 to 11 gram per day. So, we treated our patients with IV HCM and EPO, and by 32 weeks of gestation, she achieved the HbA of 10 gram per day. Coming to metabolic acidosis, our patient had a bicarb of 16 at the time of presentation, but after initiating on intensified MHT, it was maintained around 20 millimoles per liter. But when should the pharmacological treatment be given? So the recommendations are similar to non-pregnant CKD population. So that is, it should be considered at a bicarb of less than 18 millimoles per liter. So coming to the MBD, hypophosphatemia is an occurrence which is very common with intensified MHT. So our patient also had it with the serum phosphate of 1 mg per dl. So how to treat it and what are the oral formulations that are available that we should be aware of? The first one is Atmos sachet. So each sachet contains 1.96 grams of phosphate, which accounts to about 16 millimoles. And there are phosphate supervision tablets, where each tablet constitutes 60 millimoles of phosphate. And then Joule solution, which is commonly used in children of RTA, contains about 1 millimoles of phosphate per ml. And the formula is given below. And in case of hyperphosphatemia, we should remember that in pregnancy, only calcium-containing phosphate binders are used. Sevelamer and lanthanum should be avoided. So for dosages, 2 to 3 millimoles per kg per day in 2 to 4 divided doses with a maximum of 96 millimoles per day. So for our patient, we gave Atmos sachet twice a day, which accounted for about 48 millimoles per day, and her phosphorus was maintained around 3.5 mg per day. So coming to fetal monitoring, so this is the fetal viability scan of our patient, which was done at around 30 weeks of gestation with an effective fetal weight of 1.5 grams, and her AFI was adequate, and umbilical artery doctor has showed only a mild increase in resistance with a biophysical profile of 8. So at 34 weeks of period of gestation, she developed bilateral fetal edema despite being on MHT 5/7 with adequate UF removal, and her BP has escalated to 160/90. And her labs have actually showed decreasing platelet count from 2.5 to 1 lakh, and the transaminases have increased from 36/20 to 176/88, and there was increasing LDH. Initially it was 220, which has increased to 1,280. So we suspected a superimposing preeclampsia, and an OBGYN opinion was taken. So when to suspect of preeclampsia superimposing on a CKD? So for a non-proteinuric CKD, due onset hypertension, that is a BP of more than 140/90, and proteinuria, that is UPCR of more than 30 mg per millimole.
Dr. Suguna, you will have to cut down because we want to discuss the cases. You are giving a full lecture on pregnancy and I think we can discuss it later, but I think if you tell us what the patient went through and that would be important. It's already 7:15 and we have 2 other cases to discuss.
Suguna, skip the theory slide. Just go to the patient management slide.
Yes. Yes, ma'am. So antenatal steroids were also given to this lady. According to ACH's recommendation, dexamethasone 6 mg doses IM every 12 hourly, or betamethasone 2 doses of 12 mg IM 12 hours apart can be given. 48 hours before the delivery, we gave the patient dexamethasone 6 mg followed by similar 3 additional doses 12 hours apart. And then we also have given her magnesium sulfate loading dose of 4 grams. And then after taking OBGYN opinion, she was taken up for LSCS at 34 weeks of period of gestation and a male child of 1.9 kg was born with a good APGAR score. So this is an important thing that for the patients with CKD who are in regular follow-up, we have to advise, we have to counsel them regarding the contraception. So progesterone-based contraception is preferred, and default hydroxyprogesterone should be avoided due to its association with decreased bone density. Estrogen should be avoided due to increased thrombosis and worsening of hypertension. IUDs may have infection risk, and permanent methods are preferred. So our patient has a successful pregnancy outcome. Currently, she's shifted to MHD 3/7. She is still on single antihypertensive and other supportive management. So our second patient is a similar patient. We have managed her similarly to our first patient. So she has delivered a female child of 2 kgs birth weight, for which we even received accolades from MOHFW through Twitter. And our third case is actually a CKD non-dialysis patient. We've managed her conservatively, and she actually successfully delivered twin girls, each weighing 2 kgs and 2.3 kgs respectively, both with good APGAR score. So the take-home message is that with increasing patient survival and better management of CKD, both non-dialysis and CKD 5D also getting pregnant, and it is no longer being a rare occurrence. So we have to remember here that not one but two lives are at stake, and hence awareness about guidelines of management of pregnancy and CKD is the need of the hour. And successful delivery with live child is worth all the effort. Thank you.
Thank you. Manisha, any specific comments you want, or maybe we can otherwise?
No, so the thing is, like we all of us read in textbooks about management of pregnancy.
Sure, I also must, if I'm audible, I must welcome Manisha also. And Professor Kher, sorry, I joined late.
We all got late today.
I know there was some technical hitch.
Yes.
So no, I was listening to the wonderful presentation and management by Dr. Manisha's team, and she also told us that possibly there were another 2 or 3 children which were born. And logically, one point I wanted to ask you, we all now know that the outcome of pregnancy in dialysis patient is gradually improving.
Yes.
Like 10 years, 15 years back, the outcome was pretty dismal and there were rare case reports. But now, with whatever your student has also told us, that aggressive dialysis of almost 36 hours per week, the outcome of pregnancy success is going to almost 50 to 80% also. Your comment on that, why this is improving now?
So I think it's just a matter of taking care, and I mean, hello? Am I audible? Yeah, sorry.
Yes, ma'am,
so so I think it's just following all the guidelines to the T. So better nutrition, intensified dialysis. I mean, intensified dialysis, though some papers say even with routine dialysis, it's fine. But if the patient does not have residual renal function, intensifying the dialysis, and sometimes even nocturnal hemodialysis, which is done in many centers, or even hemodiafiltration. Hemodiafiltration further improves the outcomes. So in our centers, government centers, this was the first time when we could deliver a woman on chronic dialysis successfully. And in one of the cases, even a twin delivery also occurred. So the only thing, we run with basic facilities and intensification of dialysis, 20 hours per week. Our patient had residual renal function, taking care of the diet also. So generally, we just read it in theory, but do not apply it practically. Here, we had to move the machinery and get that 73 gram of protein diet and intense monitoring, stepping up the erythropoietin dose. So definitely it's a challenge. We were also faced with the challenge of hypophosphatemia, which is very difficult to manage with the intensified dialysis. But with proper supplementation, we could, do that. So I think that itself was a rewarding experience when we could have successful delivery. So I do not know about other centers. I mean, what other centers have experienced? Dr. Kher's center, your center, or Shruti center, what experience you've had with successful pregnancies in chronic dialysis patients? We have huge load of chronic dialysis patients.
Yeah,
but
I think
this was the first time.
I think what, Manisha, I would say that the first thing that nephrologists should do is, whenever the patients are referred to them or patients of chronic kidney disease want to get pregnant, I think it's very important that these are planned pregnancies and not unplanned pregnancies. Unfortunately, in our country,
Absolutely.
patients become pregnant on therapies without any planning, and then you have to manage as an unplanned pregnancy. And obviously, an unplanned pregnancy, the outcomes are not going to be as good as it's going to be in a planned pregnancy after
Absolutely.
discussion about everything. So that's both for transplant recipients as well as for CKD patients, young patients is very important. And Sugama made a very strong point about talking about contraception. And that's extremely important. And I think in our day-to-day practice, we neglect it. We don't talk about it as much. So it's very important that nephrologists start talking about contraception in young people, because if there is an unplanned pregnancy, it is worse than having a very, very difficult kind of management in these patients. So planning for pregnancy is extremely important. But saying it easier, but in our country, then we have all kinds of people. I have had patients on cyclophosphamide who became pregnant, and I had to continue therapy. I had to continue. This was way back in Sanjay Gandhi Institute, and we had to deliver this patient on cyclophosphamide. She was taking cyclophosphamide and came with pregnancy. It came with 6 months of pregnancy, unplanned, totally not. So that's one. I had also a patient about 20 years back in Apollo, which was a planned pregnancy with a moderate risk creatinine. She was hell bent upon going through pregnancy. We had given her a very high risk of pregnancy, but she said that she wants to go through it and take all the. And she also progressed to dialysis, and we had to keep her on dialysis for about 3 months. Intensified dialysis. That is the time when it had come about 20 years back. I think the earlier Canadian studies had suggested that doing dialysis on a daily basis in these patients. And we dialyzed her also on a daily basis 20 years back in Apollo Hospital. Delivered her child. This pregnancy wasn't as successful as yours, but the baby remained in the ICU, which we had warned her for about 6 months for growth catch up, as well as for lung maturity and all that in the ICU. So she had a very, very expensive pregnancy, but she had wanted it to be like that. I have had patients on CKD early stages, planned, and transplant recipients also planned pregnancies and all. They have been reasonably good, successful outcomes and all. So I usually am very pro for women who want to have children and they are very fond of having their own children. Then it's good to sort of allow them to become pregnant, but it has to be planned. You should have to talk to the obstetrician also. So there must be a close kind of contact with the obstetrician and the nephrologist, and they obviously, like what Sugam shared, is the kind of care that you need to give to these high-risk patients, both transplant recipients as well as chronic kidney disease patients. And obviously, if patients go on dialysis, then they pose different kind of challenges. And another important point which you also made is nutrition, extremely important, totally neglected in our country. So taking care of these patients, success will not happen without, you might give them dialysis, but they become severely hypophosphatemic if they are not eating. There's no way you can treat hypophosphatemia without good nutrition. It is going to be extremely, our drugs for hypophosphatemia are poor. The amount of phosphate that is available to them, they will have to take so many tablets to achieve that kind of phosphate repletion in these patients. So I feel that I must congratulate you. Exceptionally, very well managed, and you have had 3 successful pregnancies in these advanced chronic kidney disease, and I'm sure they were probably, most of these were unplanned rather than planned pregnancies. Then you had to handle them after they had come to you with pregnancy.
Yes, sir. So thank you, sir. And only one point I would like to say is sometimes the pregnancy in patients on chronic dialysis is missed because we have that thing in mind that they are mostly infertile and all that. And the symptoms of pregnancy, the early symptoms, morning sickness and all, they resemble exotemic symptoms. So, and the beta HCG is not a good test to diagnose pregnancy. Yeah. So we need to do an ultrasound. So it was like when during my PG days, I mean, we missed one pregnancy. I mean, it sounds so foolish, but this is what happened. So we could find out about the pregnancy only when ultrasound was done. We never imagined a patient on dialysis would get pregnant. But with the improving quality of dialysis, improving availability of erythropoietin, iron, and minimum thrice weekly dialysis, we are seeing patients, and we should keep this in mind and be ready to tackle it. So thank you for your comments.
No,
Thank you.
Yeah,
think,
no,
I think I fully agree what Manisha and Professor Kher said initially. See, we had a feeling that once a person becomes CKD, his person is infertile and person anovulatory cycles and person is gone. But these days, with good dialysis support, with good management, people are becoming fertile. The fertility stays even up to the time of dialysis. And as you rightly said, possibly because of better nutrition, good dialysis. So one should be aware that the contraception must be taken. And it is very difficult. I remember one case, it was not a dialysis patient, CKD patient with FSGS. And the lady was losing 6 to 8 grams. And then gradually she was pregnant. She said, I don't want to abort. I said, all right. I said, now she is losing 8, 10 grams of protein every day. And to maintain that nutrition and to give her albumin repeatedly, it was extremely difficult. And her gynecologist was in AIMS, All India Institute in Delhi. And I was a nephrologist that time in Venkateshwar Hospital. She'll say, no, you will stay my nephrologist. I'll keep on having my consultation with gynecologist. But fortunately, timely delivery, a lot of good nutrition and giving albumin, we could sustain the pregnancy, and she delivered in AIMS successfully. And she, of course, she comes to meet me. So what is I'm saying, it is pretty challenging. What you have presented is not a easy joke. It takes your total night's sleep that to manage such patients, keep a nutrition, treat the hypophosphatemia in them, and keep in mind again that fertility is possible. More patients on dialysis are becoming pregnant today. So keep your vigil, and the timely diagnosis is important for them.
Thank you. Yeah, I think we can move
I
to the
think we
second
can,
patient.
yeah.
And Shruti is going to take us through a difficult transplant patient, I would guess.
Yeah.
Shruti is a immunologist, nephrologist, actually. What should I say about Shruti? And
you said she's a
extremely
wonderful person and a wonderful teacher.
yes, very good. She has special, a nephrologist who has had a special training in transplant immunology, and therefore she is obviously making headlines in the country and outside our country. So Shruti is a very dynamic nephrologist, and I would request her student, I think Dr. Hepal Vora.
Yeah, I think he's a consultant
He's a
nephrologist
consultant.
So,
Okay.
pediatric
Who is
nephrologist.
going to present, Shruti?
so good evening, sir. Thank you very much for giving us this opportunity. Dr. Verma and Dr. Kher, it's always a pleasure to interact and learn so much from both of you. Dr. Hepal is my colleague, pediatric consultant from our Institute of Renal Sciences, and she manages a lot of complex cases together. So I would request her to present this case because she has taken this case ahead. So she will discuss this case, and then the points which come out of it we can discuss. Hipal, you may want to start presenting.
Good evening, everyone. I'll start with my case. Yeah. So we had a 9-year-old female child who presented in August 2011. She was a diagnosed case of end-stage kidney disease and was initiated on CAPD. The native kidney disease was not known. It was probably a chronic tubular interstitial disease. She presented to us in February 2013, and that was for the renal transplant. She underwent a living-related renal transplant on 16th of April 2013. Her grandmother was the donor. Her paternal grandmother was the donor. and the HLA mismatch for ABDR was 4/6. Induction agent was thiboglobulin, 3 milligram per kilogram, and maintenance immunosuppressants were prednisolone, tacrolimus, and mycophenolate mofetil. Her post-transplant course was very smooth until 2018, that is almost for 5 years post-transplant, when her creatinine was stable between 0.7 to 0.9. From 2018 January, it started increasing. Now, in between, about in December 2017 to Jan 2018, she developed diarrhea. It was found to be non-infective diarrhea, and the mycophenolate mofetil was switched to azathioprine. Parallelly, we have the graph for the tacrolimus levels, where they were fluctuating and they were adjusted. The doses were adjusted, targeting a level of 5 to 8 nanogram per ml. When she was switched to azathioprine, the tacrolimus level was about 5 to 6. And then slowly, towards June, July 2018, the creatinine started creeping up from 0.9 to 1, 1.3, and 1.5. So here she presented with allograft dysfunction. She had hypertension. There was trace proteinuria with UPCR of 0.8. In July 2018, with creatinine of 1.5, the transplant kidney Doppler was done, which was suggestive of echogenic kidney with poor CMD. Serum DKV PCR was negative, below 100 copies per ml. PRA screening was done as a part of workup for the allograft dysfunction, and it was positive for both classes, class 1 and class 2. At the same time, transplant kidney biopsy was done. And these were the findings of the allograft biopsy. On light microscopy, 1 out of 5 glomeruli was completely normal. Interstitium showed lymphocytic infiltrate, mild acute tubular necrosis with foci of tubular atrophy and interstitial fibrosis. There were no viral inclusions, no isometric vacuolization, and mild medial hypertrophy of the vessels. C4D was mild focally positive. And with all these findings, a possibility of ABMR with the background of PRA being positive to both the classes was considered. We went back to the evaluation and we found the HLA typing to ABDR, and of course it was 4/6 mismatch. We went ahead with the single antigen bead assay, and where we found HLA antibodies to C and DPDQ. So we had, fortunately, the donor was available and we could do the detailed HLA typing of the donor for C and DQ. And when we did this for the donor and recipient, we found that there were DSAs to the donor, to HLA-C and DQB1 both. With all these background, we planned the management for ABMR, chronic antibody-mediated rejection. We pulsed her with methylprednisolone of 250 milligrams for 5 days. Injection rituximab of 500 mg, 375 mg per meter square was given, and IVIG 2 gram per kilogram was given. Subsequently, the creatinine remained stable at 1.5 to 1.7 until 2019 August, that is for another year and a half. But the proteinuria kept on worsening and the UPCR kept on rising from 1.5 to 3 to 5 to 7. And the tacrolimus level was maintained at the higher level with the background of antibody-mediated rejection. Over next 3 to 4 years, she gradually progressed to end-stage kidney disease and was initiated on peritoneal dialysis in April 2023. However, even when she was progressing towards end-stage kidney disease, retransplantation was there in discussion with the family, and the parents were keen to plan for the second transplant for her. She was not doing well on peritoneal dialysis, had uncontrolled hypertension, poor appetite, nausea. Meanwhile, her younger brother also progressed to end-stage kidney disease. Now, this made us very curious to know what would have been the etiology of chronic kidney disease in both the cases. Being a sibling, and we did not know the cause of ESKD in our index case. So we went into the depth. So there was a history of consanguinity between the parents. And since now genetic studies are available, we did a genetic study, whole exome sequencing for both the siblings. And interesting result came in. INVS mutation was there, leading to pathology that is nephronophthisis type 2. It's an autosomal recessive inheritance, and that was the likely pathogenic mutation in our index case. The same mutation was found in her younger sibling and was the same cause for CKD in both the cases. And we did the Sanger sequencing for both the parents, and both the parents were found to be carriers for the same gene. So they both were autosomal recessive carriers. Nephronophthisis is autosomal recessive disease. It's a kind of cystic kidney disease, the most frequent genetic cause for end-stage renal disease up to third decade of life. About mutation, 11 different genes are found to code for the cysteine protein and nephrocysteine, and they lead to NPHP from type 1 to 11. Nephronophthisis is a Greek word meaning vanishing of the kidneys, which relates to progressively smaller kidney size with advancing kidney diseases. 3 different forms, that is infantile, juvenile, and adolescent nephronophthisis, depending on the age of presentation, are found. Juvenile is most common. There is reduced ability of kidneys to concentrate solutes, chronic tubulointerstitial nephritis, cystic renal disease, and progression to ESRD by age 30, characterized by polyuria, polydipsia, secondary enuresis, and anemia. So that's how a nephronophthetic kidney looks and the presentation. In our index case, it was INVS mutation leading to nephronophthisis type 2, that is the infantile type. And the index case presented in first decade of life by end-stage kidney disease and her sibling in second decade of life. Now, how does a patient with nephronophthisis behave post-transplant? So this illness has an excellent post-transplant outcome and graft survival. Disease recurrence has almost never been reported after transplant. Genetic diseases with an autosomal recessive mode of inheritance, such as nephronophthisis, are also usually not contraindicated for living kidney donation. So the parents who were autosomal recessive carriers could have been safe donors for both the kids. Coming back to our case, she was already on peritoneal dialysis, and we were looking for a probable donor. She was highly sensitized due to the previous graft and history of blood transfusions. So a single antigen bead assay was already done in December 2022 when second transplant was contemplated, and a large number of antibodies were found with really high MFIs. So we had found, going ahead, father may not be the suitable donor as previous donor was paternal grandmother, and she will be exposed and there may be some shared antigens between the father and the grandmother. Mother was already worked up as a donor for the younger brother. So a maternal aunt came forward for donation, and she was the prospective donor. So these were the donor and recipient HLAs. And there were 5 by 6 mismatches in class 1 and 6 of 12 mismatches in class 2. And the CDC and flow cross matches were negative at the time of workup. we had DSAs, positive to DRB3 with a low MFI of 1375, but a high MFI of 31,000 to HLA-DQB1. Repeat CDC and flow cross matches were done before we planned desensitization for this child. As this child was not doing well on dialysis and couldn't wait more for transplantation, the plan was to desensitize this child and take up for transplant, explaining the risk of antibody-mediated rejection. Injection rituximab 200 mg was given 1 month prior the planned transplant in Jan 2024. Visalone, mycophenolate, mofetil, and tacrolimus were started, and plasmapheresis was planned before the transplant. She received 3 plasmapheresis initially, post which an SAB trend was done, and which showed a slight drop in the MFIs of the antibody of the DSAs. Subsequently, 2 more cycles of plasmapheresis were given after the SAB trend report. Induction agent of 50 mg thymoglobulin, that is 1.5 mg per kg, and another 200 mg of rituximab were given on the day of transplant with MPS of 500 mg. And maintenance immunosuppressants were continued, and the tacrolimus level was targeted between 10 to 12 nanogram per ml. Post-operative course was uneventful. The creatinine dropped well post-operatively and stabilized at creatinine of 0.6 to 0.7 milligram per deciliter. She was discharged on 28 February, that is 6 days post-transplant surgery. On a follow-up of day 6 post-discharge, she developed fever, and there was a rise in creatinine from 0.6.7 to 1 milligram per deciliter. We thought of pyelonephritis as there was a DJ stent in situ, which was removed, and antibiotics were given. But in next 48 hours, there was a further rise in creatinine to 1.4 milligram per deciliter. At the same time, transplant kidney Doppler was done, which was normal, and she was planned for an allograft biopsy. This biopsy showed 10 viable glomeruli with no glomerulitis, dense patchy infiltration with significant lymphocytes and neutrophils, tubulitis T2, interstitial inflammation I2, peritubular capillaritis PCT2, no arthritis or thickening of vessels, no BKV inclusions, and IHC for C4D was 2+. However, with this kind of with this kind of biopsy, wherein a T-cell mediated rejection, acute pyelonephritis, and a probability of ABMR, all the 3 were entertained. She was treated with antibiotics and solumedrol at the same time, and we had a good drop in creatinine with this itself. At this time, she did not have any hypertension, she was non-oliguric, and she did not have any proteinuria. And with such a prompt response to solumedrol, we did not do aggressive management for ABMR, that is any plasmapheresis or any other process. We just treated her with antibiotics and solumedrol, and we got a good response. She was discharged on oral antibiotics. She has been stable since discharge from March 2024 until date. This is a table showing her gradual weight gain until date and improving hemoglobin to almost 12.5 gram per deciliter. She has been having some phases of leukopenia, intermittent. Platelets have been fine, and the creatinine stable at 0.8 to 0.7 milligram per deciliter. The tacrolimus trough levels are maintained between 6 to 9 nanogram per ml, and there is no proteinuria. UPCR was just 0.11. Her current immunosuppressions are prednisolone 5 mg, tacrolimus 3 and 3 targeting the level, mycophenolate mofetil 360 mg 1 BD. She is on valganciclovir and cotrimoxazole prophylaxis, and she is also on a nitrofurantoin prophylaxis for to prevent urinary tract infection. So I would like to discuss the key messages in dialysis versus transplant. So transplant is always a better option, especially in pediatric age group. This kid had undergone first transplant at the age of 10 years. The graft lasted for 8 to 10 years, and she was on dialysis at the age of 19. For her, definitely a long-term dialysis was not an option. She was highly sensitized, but waiting to get a suitable donor was difficult as she was not doing well on dialysis, which is why this high risk desensitization, HLA desensitization and transplant was planned for her. Through this case, we can go through the process of how to approach a sensitized patient, the importance of PRA screening and single antigen bead assay, can go ahead with desensitization and transplant if the CDC and flow cross matches are negative, explaining the risk for ABMR, which can never be negated. If the CDC and or flow cross matches are positive, then we have to look for other donor or paired kidney exchange with acceptable mismatches. And finally, the importance of genetic study, which helps us understand the etiology of chronic kidney disease, and it definitely guides us for its relevance post-transplant. Thank you.
No, I think Dr. Vora, excellently managed case and good teaching avenues, multiple. You had done initial transplant, the patient had ABMR, patient was well managed with ABMR and carried on after that also for quite a few years. The transplant lasted for 8-9 years. And then the second transplant you did for the lady, for the young girl, and that too the highly sensitized patient. You desensitized her well, and later the one of the problem what she had possibly was T cell mediated rejection that she developed. I don't know whether the pyelonephritis component was how much was there or not. More of a T cell mediated rejection, and that too she has responded well, and she is doing well, very well managed. And incidentally, you also told us that patient had the genetic, and by genetic analysis you could find the basic disease what was there, and it's encouraging because we all know nephrothesis is a benign disease as far as transplant is concerned. No, very nice. Why did you consider about pyelonephritis in this patient?
So when she presented with fever, there was pyuria, and she had a tendency to, when we think pyelonephritis as a probability, so we thought of covering her both with steroid and antibiotics, and there were some neutrophils in the biopsy as well. So,
okay. Dr. Kher, please.
Yeah, no, I think the question always remains is that when a patient is sensitized with anti-donor specific antibodies, there is always going to be a challenge in managing these patients. And these are young patients. You would want long-term survival of these grafts. Now, with already sensitized patients, it's true that those who are CDC and flow cytometry cross-match negative, they will do better than those who are one of these is positive. Obviously, they would be, then one will have to look for other donors as well. My worry only is I hope this child does well, because this is the second graft for the child. And I wasn't very sure, was anti-HLA antibodies done at the time of biopsy also, or maybe later?
No, sir.
Not yet. So
Not.
it has not been monitored,
The
because
patient has been
would
told to do it, but they will do it in their time, because I'm sure they have
Okay.
spent a lot of finances.
no.
We have given them a prescription so that we can see the trend after desensitization, whether
Right.
the antibodies are going up or down.
Yeah, because the patient is already sensitized, and the B cells, the memory B cells, are not going to go away.
They
If
are
they are
not
going to
go
create
away.
it, they're not going to go away. So that's a kind of a worry on a long-term basis, because you would want this graft to survive for very long for this young child. I hope she does well, and all our immunological fears, which Shruti and I and nephrologists all over will keep on worrying. But I hope she breaks all those barriers and continues to do well.
It
I'll
is
pray
still
for her.
only 3 to 4
Yeah,
months, so we have to
that's
wait
right.
and
Yeah,
watch. Yeah,
yeah,
it's
that's
too
very
early
true.
to
That's
say.
very true. Yeah,
But
too
you
early
know,
to say.
sometimes we are pushed to the wall, and because the patient was not doing well, there was no time to wait for a suitable exchange donor to be available. So this had to be done, and the parents
Yeah, yeah.
agreed to it.
No, yeah, no, I would agree. Although the antibody titers, the donor-specific antibody titers, 32,000 is not easy to
There
sort
is
of.
a caveat there,
But
because for
yes,
the students, I would want to say that, you know, sometimes the titers come very high, and with that, the flow cross match was negative. So that is
Yeah.
a little bit of a discrepancy, which I would say, and that is because sometimes these class 2 have a lot of denatured antigens on the beads, and sometimes the MFI values may come really high, which is false. So
yeah,
I would,
that's exactly what I was going to talk about, is that if the flow cytometric cross match, and your flow cytometric cross match is good, if you're very certain
yes,
about your flow cytometric cross match, and if that is negative, sometimes when you look at these MFIs, they may not fit into this flow cytometric CDC cross match. With
correct.
30,000, her CDC cross
Yeah.
match should have
Should have
also
come
been positive.
positive.
So should have
Yes.
been positive. So
So
I
that
would
was
think that
one teaching
yes,
point I
yes,
wanted for
yes,
students,
yes,
that,
yes,
you know,
it's very
sometimes
important.
when you exceptionally see very high MFIs and you see the cross match is negative, you will have to go back and talk to the lab that there is some discrepancy. Why is this happening? So when
That's
you
very true.
denature these beads, the MFIs usually drop down to 1/4 of the numbers.
Yeah,
So
I
her
think that's
MFIs might be around 8,000 to 10,000 is what I can think out when I'm seeing the results.
yeah, I would agree with that. And I wanted to emphasize the same point, that just don't necessarily always believe. If you have a very good CDC and a cross match, flow cytometric cross match, I think all transplant physicians should trust those values. MFI story of flow cyto of these Luminex cross matches or Luminex antibodies is still an evolution, and I think we still learning as to how to entangle all the complexities that may be entangled in these. So I think you should trust flow cytometric cross match and CDC, but they must be good. You must be
We did
talking to the
not,
immunologist.
we did not do a complement binding assay here. Now it is available in our lab.
Yeah,
But
yeah,
that time, because it's a little costlier than the SAB, so if we are stuck with a lot of antibodies, we can always do a complement binding assay.
right.
And if we find that those DSAs are not complement binding, our flow cross match is negative, then we can have a little bit of a comfort zone to still think of going ahead with the transplant, of course with desensitization, because we can never be sure even if there is no complement binding, because
Yeah, yeah,
most
yeah.
of the literature say that do not disregard even if they are not complement binding,
That's right.
but it
That's
can
right.
add to a layer of our comfort.
Yes,
Yeah,
yes,
so if I
that's
can
very
make
true.
a comment.
Shruti,
So
for benefit of students, can you just tell them that what desensitization protocol you follow?
So see,
Low,
when
low
you want
dose
to
IVIG, what?
desensitize, when you want to desensitize, you usually want to categorize the patient as a very high risk, moderate risk, or low risk. So there are a lot of scoring systems available nowadays. Latest articles being from Dr. Stan Jordan's group, where they are trying to risk stratify the patient. So if you have an MFI of between 5,000 to 10,000, you calculate the MFI of each and every DSA and add it together. If you find that the DSA's total is coming between 5,000 to 10,000, you are at a low risk of antibody mediated rejection after a desensitized transplant. Then you look at the moderate risk, which is 10,000 to 30,000, and then 30,000 and above. And it is said that if your total is less than 17, then your transplant is going to have a lower risk of antibody-mediated rejection. Once you decide that you want to desensitize this patient, then the usual protocol, say around most of the centers all around the world and in our country, we will want to first remove the antibodies mechanically. That means you want to do a plasma exchange to remove the circulating antibodies, and you want to try and minimize the production of these antibodies by giving monoclonal antibodies like rituximab. Now there is another monoclonal antibody like ocrelizumab which is coming in, which is a little higher version of rituximab and a little safer. But these are usually given to deplete the B cells which are going to produce antibodies against the for HLA antigens. It may be donor specific, it may be non-donor specific. So usually by day minus 15 or minus 14 pre-transplant, you want to give a depleting antibody, a monoclonal antibody to the CD19-20. So you are inducing a depletion of these cells and you are indirectly reducing the production of these antibodies. When you are approaching the transplant a week, 10 days prior to transplant, you will do plasma exchange on alternate days, followed by IVIG. IVIG can be given as a total dose of 2 gram per kg, total doses, the last dose being 1 gram per kg before the transplant. Once you go for the transplant, you can give induction immunosuppression as thymoglobulin versus basiliximab with a rituximab given at the end of the 5th day or 7th day. Now, there's a caveat here that when you use thymoglobulin along with rituximab, you have a higher incidence of leukopenias, you have a higher incidence of tuberculosis in our country. In our own study in our department, we have seen that when you use Ritux and ATG together, you get a lot of tuberculosis, urinary tract infections, BK viremias. So be careful when you use this combination. So if you see in this case, we have used a very small dose of thymoglobulin along with rituximab. So it amounted to some neutropenia, but the patient has not gotten any severe infections as of now. Post-transplant, you want to monitor the antibody titers starting from day 15 onwards, 3 monthly to 6 monthly, to understand if the titers are going up. Of course, we monitor the renal function. Rituximab may be repeated post-transplant depending on your severity of the sensitized status. This is one protocol. Now, there are a few more new protocols which have come around from the western part of the world, where some new drugs are coming in, like imlifidase, which is an anti-streptokinase enzyme. So what it does is that it is a lysing enzyme which is given to the patient a day prior to the transplant. It simply beheads the IgG molecule where the Fc receptor, the Y, is beheaded with the stem. And that is how the depletion of the antibodies is done. Then alemtuzumab is given on day 4 post-transplant, and pre-transplant the same protocol is followed with rituximab and plasma exchange. So this has revolutionized the treatment of sensitized patient, but overall if you see, the rejection rates are still remaining around 29 to 30% in these desensitized category.
Yeah.
So this is the desensitization protocol which overall a student should understand.
A question from audience, Dr. Puneet Ram. Any proson phenomena was looked for?
Yes. So every flow cross match, so this flow cross match and CDC cross match is from our lab, and every cross match is diluted to 1 in 16. So with 1 in 16 dilution, all proson phenomena will be caught up, so that when you have very high titers of antibodies, and if there is a competition in binding and the flow is coming negative, by 1 in 16 that effect should vary.
I think, Dr. Verma, I would suggest that every nephrologist must always talk to the lab guy and find out, and also talk about this proson phenomena, dilution. This should be a standard practice of flow cytometric cross match, which must be standardized across. the country as well. And so that's very important.
Sir,
And I think
I may want to request Hepal to just show that slide of the cross match. Hepal, if you can display it, so for the students, I can show the cross match details so that when they read the cross match, they understand what to see.
Another question to Dr. Heppel is that urine culture report in the second case, is it there?
Yeah. It was there, sir. It was staph hemolyticus that was positive with significant colony count and was sensitive to ticoplanin and which was given to the patient.
Hepal, the cross match report.
Yes.
Yeah, if you can make it full screen. No, previously. Yeah, no. Yeah, so if you can see this report, the first panel is showing the flow cytometry cross match and the second panel is showing a basic CDC cross match. So if you see the flow cytometry cross match, you will see the first row showing an auto T cell cross match, then you have an auto B cell cross match. Okay, so this is an auto cross match done with the flow cross match so that you are ruling out auto antibodies. Then comes allo T cell, allo B cell. And if you see that these are negative in the neat sera. Then if you see below 1 in 8 and 1 in 16 dilutions have been done and all the readings have been given as the median channel shifts, the ratios. And then we have said it is negative and then the overall report written in red shows it is negative. So all the dissections or all the bifurcations of a flow cross match are displayed in this report. So when you are reading this, a physician, a transplant physician or a surgeon, whoever is looking after the patient can easily understand that yes, the flow cytometry cross match was done and then auto T cell, auto B cell, all negative, allo T cell, allo B cell, all negative, and then done in two more dilutions, 1 in 8 and 1 in 16, so that the prozone phenomenon is also removed, and all of these are negative. Now, for the student's benefit, if someone has received rituximab, then you will find a B cell sometimes turning positive. That is because the CD20 has blocked the bonds, and that is when we add a pronase. When pronase is added, then the CD20 effect is taken off, and the cross match from a B cell positive will turn to negative. So it is extremely important for you to tell the laboratory that a rituximab has been given to the patient, yes or no, because otherwise you will get a positive flow cross match and you will think that it is a pathologically positive cross match. People, you can take the screen now.
No, thank you. It was very good.
So Dr. Dr. Kher and
Yes.
Dr. Verma, one question, like in our hospitals, we don't always do a single antigen beat cross match. I mean, SAB we don't do, we just do a CDC and flow. So what's the routine practice across the country? I mean, I'm not talking about sensitized recipients most of the time, but SAB, again, it becomes very costly. At least the government doesn't provide it free of cost. So
no, see, what we follow is that we take a sensitization history. So if there are no blood transfusions, no pregnancies, no pre-transplants, then we do a CDC cross match and a flow cytometry cross match. And if these are negative, then we go ahead. We don't do. However, in highly sensitized patients, which is those patients who are had previous transplants or have had pregnancies or have received a lot of blood transfusions, we would do a single antigen bead assay also in them to look for it. That is what our protocol is. That's what our protocol
Yeah, I
is.
fully agree. Dr. Manisha, what happens these days?
80% of our patients, 80% of our patients fall into the first category, and usually they will get away with a flow and a CDC cross match.
Maybe our patients slightly more. I think it is 50-50. 50% patients do give a history of blood transfusion or something. So around 50% of patients, or maybe more these days, I'll say, we are doing DSA. Because that gives you a good night's sleep. You feel comfortable if you have done a DSA for the patient.
Yeah, so only thing, sir, I fully agree with what you have said. But the thing is, second transplants, okay, definitely we are like going for SAB and all that. But most of our patients, pregnancy is a problem. I mean, female patients, pregnancy and blood transfusions are there. And still in those cases also, we are, as of now, sticking to CDC and flow.
So, Dr. Manisha, we can always do a PRA, which is an
PRA
intermediate.
we are doing. Yeah, that's what. So
Because
that's what.
PRA can give you a good idea. And Dr. Manisha, one secret from the lab. What happens is when you do a PRA ID, what happens is that every bead has antigens on it. So a laboratory person can easily tell you whether these are going to be donor specific or no. It can save the cost of the patient.
Yeah, exactly. So that's what the
That
point
can
I was
be done,
making.
which I still do for municipal hospitals here. When they call me, I said, you just send a PRA. I will tell you whether there is a DSA, yes or no. Don't go for SOP, SAB.
So this is the
that can be
protocol we
done.
are following. Yeah, this is the protocol we are following. We are doing CDC, flow, and PRA. So SAB, we are, I mean, because
At the
it's not in
same
the system,
time,
we are not
we should
doing
be
it.
careful because we have just concluded a study where in the lab, where we have found that around 33% of alleles of our population are still not present in the beads.
Oh,
That's
So this is a Western population because see in India the HLA varies as per the region. So the South Indian HLA, the West HLA, the East HLA are different. So what I did was that I have gathered the HLA of the West zone and I have put it together and I have evaluated the beads that what is absent and what is present. And I have found that in the Western zone, at least 33% of alleles, antigens are there. Antigens 90% to 99% are there. But 33% alleles are absent on the bead kits from both the vendors. So
Yeah,
we have to
actually, you
be
can.
careful.
Yeah, you have also. We published a paper in the IJ, and IJ had done it. And this was looking at the HLA prevalences in our country, which are available from, because these are available from bone marrow transplant
Yes.
registries and all those. So
Yes.
you can,
Yes.
and you can calculate looking at what beads are available, what bead antigens are available.
Yes.
You can calculate actually, and it turns out what you found in the Western population is that overall in the Indian population, although regions might vary, but prevalence of 25 to 30% of antigens are not available in our. So this is
Alleles, to be
an allele.
specific.
Yeah, alleles are not.
Antigens
Yeah,
are
alleles are.
broadly available. It's the
Yeah.
alleles which, like just today,
Yes.
I think there is a question on the peculiar group chat where 3503 is in question, where 3503 B for 3503 is there on the donor, and the person asking is worried that this is a DSA, but 3503 is not present on any of the beads. And B35 is a very antigenic uh, antigenic molecule. So giving a B35 as a DSA might be detrimental to the patient, even if the flow is negative sometimes.
Just final question to you. I think we have exceeded time today. People, if they have to give blood transfusion, generally say you give under cover of immunosuppression. That let's say 1 week before or 10 days before you have to give. You start immunosuppression, give under the cover of immunosuppression. Your comment on that?
So this was there is some literature on saying that we should give immunosuppression a week prior or you take care of this. But now the literature says that you can leukodeplete the blood, wherein most of the blood banks can leukodeplete your packed cell and give you within 2 hours. And the second option is if you really don't have time, then there are filters available because the HLA antigens are on the leukocytes. So you just want packed red cells to be given. So there is RC1 filter which is available where if you pass the blood while being transfused through that filter, it's like a small pouch which can be attached to the bag, the blood bag. And when the blood passes through it, all the leukocytes are collected there. So this is a good option and it is not costly. Leukodepletion at our hospital costs not more than 2,500 and an RC1 filter MRP is 3,500. So this is a good way to prevent sensitization if you have to give blood in dire circumstances. Giving
luckily we are able
immunosuppression
to
is
do
now
this.
not in most of the literature.
So luckily, like in government sector also, both techniques we are using, sir. So that's taken care of this problem.
And see, if private hospital can charge 2,500 and RC1 filter is this much, I'm sure in public hospital it is cheaper. Matlab, the running cost of that must be really low.
Yeah, it's free as of now.
Yes.
I think, Professor Kher, you will agree that both the cases were really challenging today. The first case, it is not easy to carry a pregnancy in a dialysis patient, despite whatever advances have happened. That is again a challenge. And secondly, again, to transplant a highly sensitized patient is another challenge. And both the cases have been very finely managed by the teams. I think I can only thank them, and they have really enlightened the students and made them wiser for both the cases. Professor Kher, sir, your final
no,
comment.
I think I would agree with this, that this has been a huge learning, not only for students. I think it's for every nephrologist. I can tell you, these cases don't happen here and there. They are rare, and they obviously challenge the best of the nephrologists at any time, any place. So I think extremely well done, and I think it's been very, very educational today. Very, very informative, and I'm sure everyone is benefited. I have been benefited, and I'm sure you have been benefited.
Yeah,
and I,
definitely.
on behalf of all the attendees, would like to thank both Manisha and the team, as well as Shruti and Dr. Hipal. Thank you very much for an exceptional case discussions, and thank you.
Yeah.
Thank you very much. We must thank also the Micro Labs for providing us this opportunity, and thank you again, and see you again in 2 weeks' time, I hope.
Yeah. And our apologies for joining late today.
Late, yeah. That I hope we settle the technical glitches.
Yeah, this is the first time we started the program late. Yeah.
Thank you.
Thank you very much,
Bye
sir.
bye.
It was an
Thank
honor
you,
to
sir.
present.
It was,
Thank you very
nice.
much. Thanks,
Thank you,
Shruti.
sir.
Thank you,
Thank you, ma'am.
Professor. Thank you, Kher, sir. Thank you.
Thank you.
Thank you.
Thanks, Hepal, as well. Thanks, Suguna. Thank you. Thank you.
Oh.
Thank you, ma'am.